So lecture objectives. So after the lecture today, hopefully, you will be able to describe the basic pathophysiology. You know, Dr. McNeil also does pathophysiology for lungs, so he'll get a little bit more intense, but I just give you the basics of it. Basic pathophysiology for pertussis and RSV. You need to be able to recognize the emergent and non-emergent patient, so basically signs and symptoms. How are they presenting to you in your clinic? Whether that clinic is the ER, your primary care office, or a pediatric practice. So emergent would obviously be in trouble, like, oh my gosh, that would probably be an emergency room type setting. You actually could get it in your primary care setting. We get it all the time when I was at family medicine. We have to call an ambulance to come get them, for adults and kiddos. But then non-emergent, you know, just coming in, basic upper respiratory type symptoms. But you need to be able to know, and signs and symptoms is something you're going to hear a lot as you go through PA school. Signs are basically what you are seeing as a PA. I am seeing you, I'm seeing cyanosis. Cyanosis is when someone gets blue, they turn blue around their mouth. That's not a patient telling you that. You're going to visually see cyanosis. As where symptoms are what the patient tells you. Yeah, I've been coughing for 3 days, I have a runny nose, I feel sick in my stomach. That's what symptoms are. So if you think about like subjective and objective information, has anybody really talked to you guys about that? Mm-hmm. Somewhat, just a little bit, and that's okay. That's what it's so, I hate stinking chalkboards. Who has a chalkboard in 2016? So when you have a SOAP note, you'll learn all about this in your phys guide, how to document. So when you walk into the doctor's office and you're sick, you need to tell them what's going on. This is how you write a note, basically. So SOAP stands for subjective. You don't have to write this down. This is not testable material. I'm just going to give you some stuff here. Just to kind of understand or describe to you when I say terminology like signs and symptoms. Because you've got to start thinking like that when you hear that stuff. You know what that is. Subjective is what the patient tells you. What are their symptoms? Objective is what you see on a physical exam or what signs you see. Make sense? This is your assessment. Is it 1S assessment? And plan. So what are you diagnosing them with? And how are you going to treat them? Again, not on your test, guys, just a little curl. You're going to understand how to work these folks up. What labs am I going to order, if any? Diagnostic approach, that would be imaging. If I wanted to do some imaging on you, whether it was a chest x-ray or an echocardiogram, obviously, you know, you're going to learn how to do that. The two things that we're going to talk about here, not a lot of diagnostic information. It's pretty much a clinical presentation. You'll hear that a lot as well. People say it's a clinical presentation. That means they walk in your room, you listen to them, they give you your history, and you go, yeah, I think this is what's going on with you. I don't even have to go do anything. I don't even have to order a lab or get a chest x-ray. I can diagnose you right here and there. And then obviously, how do you treat these illnesses? And then what's a differential diagnosis? What else could be going on? I will tell you, pertussis is there's not a lot of differential. It is, you hear this, you are going to know it's pertussis because it's so stinking distinct. At the very end, I'll get on YouTube and I'll play you a little video of what a kid with, it's whooping cough. I know you've heard of whooping cough. That's what pertussis is whooping cough. It is unbelievable. If you've ever had it or been around any kiddo that's had it. Another little thing here, RSV, you're getting a lecture later on bronchiolitis at 1. RSV is the #1 cause for bronchiolitis. So you're going to probably hear a little bit more about RSV this afternoon. So RSV, what does that mean? we like to use acronyms a lot. Respiratory syncytial virus. It is a virus. So what does virus mean regarding treatment? Just getting off on a tangent. I tend to do that. I won't do it too much. I'll try not to. Virus does not equal what?
Antibiotics.
Exactly right. That's right. Very good. You're going to get this a lot in your practice. Or mom and dads are going to come in. Be like, my baby's coughing, as Ronnie knows, for 2 days. This baby needs some antibiotics. No, they don't. And you'll learn how comfortable you are giving antibiotics. But just remember, there's danger with any medication you give a kid, even Tylenol, ibuprofen. So remember that. So it is a virus. It is the leading cause of respiratory tract infection in infants and young children. It's usually 2 to 8 months of age. That's kind of the most common range that you will see it. 2 years and under is like usually what I think when I have kiddos coming in. But don't ever be fooled by numbers. Don't let that be your, well, they're 2.5 or 3. It can be RSV. Absolutely it can be. Actually, 3 years of age is kind of the max where you start to knock RSV off your differential. But it's a little kid. It's a baby disease, a baby infection. It's extremely prevalent in the winter months. Winter, fall and winter are the most times that you will see RSV. You're not going to have a RSV coming in July. And right now, I know you don't think a lot about that, but once you're out practicing for a little bit, you will be more mindful of what comes in with certain seasons. Does that make sense? I mean, you know, flu season, that's totally legit. You know when that's amping up. Allergies are horrible right now. We have lots of sick folks coming in that they think they have a cold. No, you don't. You have really bad allergies. It's allergy season. So seasons are important. And that is very true. Most kiddos, by their 3rd year of life, will have had an RSV infection. Just most parents won't know it because they just think, oh, they got a cold. And a cold, a fancy word for a cold is a URI, an upper respiratory infection. There are about a gazillion bugs that cause a common cold. RSV is one of them. Not the, it's not, I mean, I wouldn't say number one, but RSV, heart influenza is a biggie for little kids. Enterovirus is another biggie. Enterovirus. And then, of course, influenza. RSV, parainfluenza, enterovirus. Oh, and this is number one. And again, this is not testing, I'm not testing, this is, you need to know this. Rhinovirus. That is like the number one cause for you and for little ones regarding when you get that cold, you know. A fancy word for cold is upper respiratory infection. So rhinovirus is number one, but RSV is definitely, any one of these viruses can cause that. Okay, pathophysiology, which is one of your objectives. It is an illness, a viral illness that affects the upper respiratory tract. Symptoms can progress rapidly. Yes, do you need to shut that? Yes, you can shut that. I was going to do it. I didn't know for sure it was open or not, though. It can progress into the lower part of the lungs and basically cause inflammation, infection in like diffuse small airway. But it is a upper respiratory tract illness. That's where it hits first. So probably not a great test question from that, right? Even though it is one of your objectives. It's not that glamorous. Cystic fibrosis is more glamorous regarding pathophysiology. And this is how you need to start thinking when you go and you start studying for your tests. I was gonna say this the other day, but I was all hopped up on Claritin and rambling on. Claritin D, it's like my go-to when I'm tired. That's horrible, don't do that, it works. If you have high blood pressure, don't take it. I know some of you are probably, majority of you are like kind of panicking now at this point. And what I was trying to say the other day about you becoming a machine and that you can, and I truly in my heart believe you will make it, you will do this, everybody makes it. After a couple of tests, you actually kind of start to figure it out, like what people will test over and what they won't test over. And you'll become more smart to that. Like by the end of PA school, my best friend and I met her while I was in PA school, I would actually, this is horrible, but we would just take a pen and just mark out everything that we knew that was not going to be in our objectives, because I wasn't even going to, I knew what they were going to ask. Because you can't write test questions over that, right? Cystic fibrosis, you can write a test question over pathophysiology. And not that all your lectures are, and I don't want you to get used to it, but I will try to kind of direct you into an area that may be very important to memorize for your test. Okay, a little bit more on the pathophysiology of it. It's more common with kiddos that are families that have asthma or atopy. Atopy is basically eczema. It's a fancy word for eczema. So obviously, asthma and eczema go kind of hand in hand. So their immune system's already decreased because of those two things. So that makes them more susceptible to RSV, or any illness for that matter. Also pathophysiology-wise, a lot of these kiddos are going to develop OM. OM stands for otitis media. You already know that. You had ENT, sorry. 40% of these kiddos will get a little upper ear infection from this. Which, if you think about it, any common cold or upper respiratory infection, this is in kids, by the way, not so much adults. We don't get inner ear infections. If you do as an adult, something else is going on. A big complication of any virus is OM, sinusitis, pneumonia. And why would that be?
Because of the connections.
Yeah, and anytime you get like a little virus, upper respiratory infection, RSV, you get a lot of inflammation in the sinuses, in the throat, in the ears. You've had it before, you've had a cold before. And this is how I explain it to parents when they're like, why do they need antibiotics versus why they don't need antibiotics? Or what is otitis media? What is sinusitis? Anytime you have inflammation because of a virus, like RSV, inflammation leads to mucus and fluid production. It's just an offshoot of it. That's why you get that runny nose. That's why you get that ear pressure here. Well, anytime fluid is stagnant or sits in any cavity, inner ear tube, sinuses, maxillary, frontal, lungs, that sets up shop for a bacterial infection. And what does bacteria equal? Antibiotics. This is how you determine if someone needs it or they do need it. So just know, common cold can turn serious. And we'll get into how you determine which is it. And I will tell you right now, and I've only been practicing medicine for 3 years, it's hard sometimes. When you're like, do I get this kid azithromycin, do I not? So pathophysiology of it. Frequency, it's extremely common. Causes, these are kind of going along with remember those causes that were really popular for ear infections, otitis media, being around smoke? Did Shelley go over those? Smoking, daycare, not being immunized, being around a lot of kiddos. And why is that, being around a lot of kiddos? They're little petri dishes. I mean, that's why. How many here have kids, just by show of hands? Does anybody have kiddos? Okay, 2 people. If your kids have ever been in daycare or been around other kids, they get sick. It's just gonna happen. People will put their kids in a daycare. Kid was healthy as a horse before. You're gonna see them all the time. They're gonna come to the doctor because they just spread germs. They're little nasty creatures. So childcare. Obviously, if brother goes, and this is why in your history, in your subjective, I always ask, has kiddo been around any sick contacts? And mom will go, yeah, you know, their cousin was sick over the weekend, or yeah, she goes to daycare. And oftentimes, Shelley probably told you guys this as well. You always document child's in daycare. Child's in daycare. I always document that in my subjective. Child's in daycare. Because it is a risk factor for the majority of viral or illnesses that we see in little ones. Crowding. Obviously, cigarette smoke makes kiddos more inflamed when they breathe it in. It just causes them to become really stuffy, that flu can be correct. Here's some more. By the way, when you go to study, I'm not saying things are not important, but I am not a morbidity, mortality, epidemiology, statistics kind of gal when it comes to tests. So don't get too crazy with that junk, please. This is not testable material. Not a lot of deaths from morbidity and mortality, not a lot of morbidity and mortality from RSV, unless kiddo is turned into something more serious. This is the biggest one that you run into with RSV that it turns into. A lot of, they can have pneumonia from it, and that's the one that will get them in trouble. Because pneumonia in a little one's serious. If you ever had pneumonia as an adult, you know it's bad. Obviously, if they already have some kind of condition that causes them to be more susceptible or not to be able to fight something off as easy, so lung disease, if they have a congenital heart disease, prematurity, those are things that can cause them to be more likely to have more serious issues or even death. Yeah, we're immunodeficient. There's no real pattern regarding race. Caucasian versus African American versus Native American. I mean, it's kind of across the board. And I can't even say really for sex either. When I had my clinic, it was males and females came in with it. And again, you do know, I think age would probably be a good thing for you to kind of focus on in a case vignette when you go to read on your test and you have a case vignette, and if the kid's 7 years old and one of the choices is RSV, you can probably mark RSV off your choice. So age would be important in regard to this for testing purposes. 2 years and under. Just remember 2 years and under. So, signs and symptoms. Is there any questions thus far? I tend to forget, ask people, do you have any questions? Any questions? Hard to screw that up. Signs and symptoms. So, mom's going to come in, or dad. I always just tend to say mom. I shouldn't do that. Caretaker is going to come in. And dads are the best though, because they're like, I have no idea, my wife just told me to bring this kid in. And they'll get mom on the phone and be like, here, talk to her. I'm like, Mom, what's up with this kid? It's really sweet. Except my husband, he'd be like, yes, she developed a cough at 3 a.m. She had 4 coughs before I would be the one that'd be like, I don't know. But he's emergency medicine, so he's a little bit more on point with that kind of stuff. So signs and symptoms. So mom or dad is going to come in and say, yeah, my baby's been coughing, she's had a runny nose, she's had a low-grade fever, she's not really wanting to eat, not wanting to take her bottle. So those are some of the symptoms mom's going to tell you. And fever is typically low grade, which by the way, Does anybody here know what a true legit fever, you're gonna get this, oh my God, this is my soap, I have many soapboxes when it comes. What is, what is it?
100.4.
100.4 and above is a fever. So when Daddy says 99, that's not her normal, she's normally 97, 99. That is not a true legit documented fever.
What is like the answer to that though, when people, we worked at an urgent care and
Yeah.
people would come in and they would be like, it's usually 97.
I don't care, they don't know what it's
Yeah.
100.4 and above. And I'm gonna tell you why this is extremely important. This is a very important role here. 100.4 and above is a legit documented fever. I don't care if they're 25, 2 years old, 3 days old. That is a temp. You know, there's different ways you can test that. What do you think the best way to test temp is? And you're gonna tell mom this when a kid's really sick and you're sending them home. You're gonna say, this is how you're gonna test, what is it? It's rectal. Rectal is the best. And if you go to an ER, that is how they test a kid's temp, a little one. They don't do this or this, and they will do rectal in a little one. This is important to tell mom, this is patient education, which that's huge as to being a good provider, a good PA is patient education. Because I've had many parents come in with their kids and are like, they have a fever. I've been giving them Tylenol and ibuprofen around the clock. And I'm like, really? Okay, because you're going to document and you're subjective. You're going to say, what's their fever been? Tell me. Well, I don't know. I just feel the kid. Okay, that is dangerous. One, because they could have had a raging fever and you don't even know it. Or they're 97 or 98 and you're giving them Tylenol and ibuprofen around the clock. And that is not, so you just be nice and say, Mom, I'm gonna need you to go purchase a thermometer and take baby's temp for me, okay? And if it's above this, you give them Tylenol and ibuprofen. Of course, you can give Tylenol and ibuprofen for pain. You don't have to have a thermometer for that, but temperature, they need to document it. And how you document fever in your note is you say, like, because mom will say, baby's had a fever from Monday to Wednesday, it's been all over the place. You say, what's the highest fever baby had? Mom will say, oh, on Tuesday it was 102.7, and that's how you document it. You'll say T-max. This is in your note, 102.7. That's how you document that. In your note, T-max of 102.7. So fever, cough can be productive, cough can be dry. I always ask that when I'm getting history from a mom or dad. Tachypnea is more of a sign. Mom's not gonna come in and say, my baby's been tachypnic. Tachypnea is when someone breathes really fast. And you'll learn your normal and your abnormal vital parameters for your pediatric population. We won't get into that now. So a sign would be tachypnic, a sign would be cyanosis, a sign would be retractions. Retractions is when their little rib cage, they're like, they're breathing in real, you can just see it. Their little tummies going in, going out. Their little sternal, they'll retract in there, and they can even retract in between their little rib cages. That's what retractions is when people say that. You'll hear that a lot. Retractions is not a good sign. Yes, ma'am.
Sorry, just really fast to go back to the fever.
Yes. Go
I
for it.
scribed, and some physicians wouldn't want us to put, if the mom said they had a fever of 99, not to put it, and others said to put in the HPI a subjective fever.
Oh,
Do you have a recommendation?
okay, subjective is actually a good point there. Subjective fever is whenever mom really does not know. Like she'll say, I do subjective whenever they did not really test their temperature. They just say, hey, kiddo was hot, or I don't really know, she's been all over the place. You don't discount mom, you say mother reports subjective fever. That's the way I do it. But if she gives you legit numbers, like yeah, on Sunday it was 103, on Monday it was 102, I will put those in there.
And if she called 99 or just 100, like baby had a fever of 99, you would just say
You would put that in there.
temperature or a
If
T-max
she
of
gives you a
99?
number, put it in there.
Okay.
My whole thing is with patient education is when you go to talk to mom after the fact, like it's the plan of care part, when you want to say, look, mom, from here on out, I really want you to check her temp legit. And if it's this number and above, that's when you're going to give her a fever reducer. And you can document that you did this. that you spent 10 minutes talking to her and you can get paid more. That's why, I mean, it's important, obviously, for obvious reasons, but it is also for documentation purposes. It's extremely important in febrile seizures that you talk to mom about, legit. Wheezing, you know what wheezing is. It's like the high-pitched musical. You can hear it. A lot of parents will actually report the symptom of wheezing as well. They'll say, I hear a wheezing sound. Sepsis-like presentation or apneic episodes in very young infants. This is when they're starting to become in respiratory distress. Sepsis-like is kid is lethargic, kid's not eating, kid has not eaten or taken a bottle in 48 hours. They have decreased wet diapers because they are not pooping and peeing because they're not eating or drinking. They have a fever, legit in your office. Sepsis is a fancy word for full body infection. Like that RSV has went to a pneumonia and that pneumonia is now taken out of that baby. Apneic is whenever they stop breathing for a period of time. That's what apneic means.
Is there a Nikki here?
Come on. I think that is adorable. I'm going to cry. And I'm going to go rip my husband up. I'm like, you ever get mad? She's never going to be mad. Okay, they're beautiful. We gotta go on. They are absolutely gorgeous. They're huge. They are but he's a snake. It's very sweet. Turn around. Okay, guys. Oh, you were fine. I was like, bring them in. I love this. Okay, so one that's not up there, and I apologize on that, would be a runny nose, obviously. Rhinorrhea. Rhinorrhea is your fancy medical term. I press you say big girl term. That's your big girl term. Rhinorrhea, that basically means a runny nose. You're going to document rhinorrhea. Mom's going to say runny nose. Yes, ma'am.
The sepsis-like presentation, is that only if they get a secondary infection, or can that be with just RSV?
No, that's going to be if there's a secondary bacterial infection. So the two things you would worry about in RSV, again, 2 and under, or 3 and under, would be sepsis, and that is secondary to a bacterial infection that has went full-blown. Sepsis is basically an infection in the bloodstream, if you just want to get down and dirty. So they got pneumonia, it went to their bloodstream, now it's just shutting down every organ system they have. That's what sepsis is. There's different types of sepsis, but in this case, that's what we're talking about. The more common thing you're going to see in the emergent patient is respiratory distress. This little one, because if you think about it, that little 8-month-old, they only have so much of a reserve in their body. So when they're breathing fast, this is very true in asthmatics as well. They're breathing fast and they're not eating and drinking as much as they normally should. Their little body is going to tire out after a while. They cannot keep up that breathing fast, the little heart's beating 90 to nothing. They cannot keep up with that. So what happens, they have these retractions, they have this weakness or wheezing, they have this cyanosis, and then boom, all of a sudden they're in respiratory distress. And that would be your tachypnea, retractions, that's signs of respiratory distress. So not to downgrade RSV, I mean, it is your little common cold, but it can be serious. So, tachypnea and cyanosis, something that would also be a sign that we tend to really look at on vitals is O2 saturation. So decreased O2 saturation. Retractions. And I'm just gonna start writing stuff in medical terms so you can just learn it now. You're gonna say decreased PO intake. That means they're not eating or drinking. Decreased PO intake. Decreased output, urine output. These are all signs. Increased respiration. Or I'll put tachypnea, sure, how do you want to put it? So decreased O2 sat, so O2 sat is, you know, that little doohickey on your finger. Anything, actually, you're not gonna believe this, oxygen doesn't start to actually drop off the curve until like 88%. I get nervous at like 91. 91% I'm like, ooh, okay, that needs to be bumped up there a little bit. So low O2 saturation is concerning, because what's that telling you? They're not getting O2 from here into their bloodstream. And that's why you have cyanosis. So decreased O2 cyanosis, retractions, tachypnic, fatigue. I hate the word lethargy. Don't ever use that word lethargy even when you're documenting or when you're present. It's the #1 litigated word, like in cases, like malpractice cases. Because what does lethargy really mean? People, moms be like, my kid's lethargic. Do you really know that? Lethargy is like, I mean like on the ground, you cannot pick them up. So don't ever document lethargy in your note. Physical exam, you know, if they're just the every average day having the little upper respiratory symptoms, you're gonna hear on, you know, and I didn't try to put too much of this since you haven't had the phys doc component of it. I don't wanna just throw you into a complete tailspin. You have your stethoscope, you're gonna listen to the little lungs. You can hear some wheezes on auscultation, so you're gonna be able to put that stethoscope on their little lung bases and hear like a high-pitched in and out. You're gonna see runny nose on physical exam. They're gonna be having just the snot coming out. It can be clear, it can be green. Obviously, if you look in their ears and they're bright red and they're bulging, they have an ear infection, otitis media. You already know that. You definitely need to, if you are starting to become more seriously concerned about an illness, you do need to assess their hydration status. So skin turner, that's where you can pick up their little skin and let it go. And if it stays tinted up, that's not a good sign. You can actually document skin turner. Cap refill is really important. That's where you push on their little, I mean, all of you guys have been sick. Someone who's probably done all this to you at some point. Less than 2 seconds to pink back up is great. Anything over that, you think, a little bit of dehydration. Also mucous membranes, you pull the little kid's mouth up, and if it's tacky, that's signs of dehydration. And these are all things you document when you're talking about pediatric patients. So wheezing, or if they did have wheezing, you can say clear breath sounds. Talk about their ears, runny nose, signs of dehydration. You can even document if the kid's crying, infant's crying, infant appears upset. Workup, again, this is one of the things that's not really a great lecture in regard to diagnosing with labs or x-rays, unless you're starting to get into more pneumonia or you're starting to talk sepsis or something more serious going on. Because otherwise, it's just a virus. You're not going to go stick a baby for a CBC or a CMP. If you do feel like there's a secondary bacterial infection, yes, you can definitely do some labs. A CBC would show you an elevated white blood cell count, right? Because that is what a bacterial infection causes white blood cells to elevate. What specifically on your white blood cell line, and you probably don't know this, there's one specific line of your white blood cell count that shows bacterial infection. Yeah, neutrophils. Neutrophils are, that's indicative of bacterial. You could get a CMP and look at their serum electrolytes, which that's kind of things going along with dehydration. Because when babies get dehydrated, their electrolytes get really out of whack. Their potassium, their sodium. But this is when kids are really sick. This is when you're thinking like sepsis or pneumonia. These are things you're going to want to order. If I really thought a kid had pneumonia, I absolutely would get a CBC on them, sure. UA, especially if they're starting to become septic, you want to get a UA on them because they may have the infection by that point in their urine. Make sure all urinary. There is actually an RSV swab. It's kind of like your rapid strep, rapid mono. There is an RSV swab that you can do into the little nose. A lot of providers, again, if they feel very comfortable with what's going on, they will make a clinical diagnosis just by, listening to the kiddo, talking with the parents. But you can do an RSV swab. I got them all day, every day in my clinic. I'd be like, swab them for the flu and swab them for RSV. There's nothing you really do for RSV if it's just your everyday RSV, but at least you have a diagnosis. So there is a swab for RSV. It's a rapid swab. It takes about 10 minutes in your lab. Nose, you just swab a little nose. If you do feel like you want to get a chest x-ray on a kid, you can. You don't really get a lot of chest x-rays for RSV. It would be more along the pneumonia route. If you thought there was like a full-blown pneumonia, sure, you could get a chest x-ray. But I don't think I've ever gotten a chest x-ray on a kid that I thought had RSV. I mean, legit RSV, and they were stable, and I was sending them home. If you do get it, and they do have just everyday run-of-the-mill RSV, they could have some hyperinflation in their lungs with interstitial markings, and that's where just the little lines of the lungs become more white. There's nothing really, I didn't even there's nothing great about the chest x-ray. If you do think pneumonia and you get a chest x-ray, you're going to have an area of consolidation or a focal area where basically there's like a white pocket. And I know Nikki will be doing abnormal chest x-rays with you guys. It's just like if you had the lungs. You really have an issue with these. If you have the lungs, that's really bad. Like, it looks like boobs, doesn't it? Yeah. Like one lobe will be just really whited out. And there's different lobes of the lung, so it can be upper pneumonia, lower pneumonia, wherever. Atelectasis is kind of like what Ron was talking about the other day. Atelectasis is just where, when you get to that very end of the tree, you have those little balloons, they look like, they're alveoli, and they look like little balloons at the end, or grape clusters. They can collapse onto each other. That's what atelectasis is. But again, these are atelectasis, focal areas, consolidation. This is your pneumonia. This is when you're getting more serious. This is pneumonia. Our everyday run-of-the-mill RSV, you do not need to do a chest x-ray, and there's nothing grand about it. Because it can, when you do a chest x-ray, what are you giving to that little baby? Radiation, remember that. Treatment, there's a lot of controversy. I remember when I was a PA student, I was on I was on the family medicine. I would do family medicine rounds with the family medicine residents, and they had to end up admitting a lot of the kiddos with RSV, either because of respiratory distress or pneumonia was a secondary issue. But it was always like, what is the latest, greatest way to treat RSV? And there's really not any grand way to treat it, unless they do have pneumonia or something else is going on. But for just in your clinic, in your office, it's just supportive measures. You're going to hear that, supportive measures. That means you talk to mom about fever and how to give Tylenol, ibuprofen. You talk to mom about push fluids, make sure babies get enough fluids. You talk to mom about nasal suctioning and nasal saline and that suctioning with the blue bowl. You talk about putting a humidifier in the room at night with baby. So just supportive measures. Because not according to, but by the American Pediatric Standards, actually some people say 4 and under, but I 2 and under. You cannot give 2 and under any type of cough and cold medication at all. And that is a big thing with parents. They like have been given their 8-month-old Robitussin. You cannot do that. very dangerous cardiac rise. The only medication you can, cough medication that you can give to 1 month and up is Zarbee's. It's an all-natural cough medicine. It's excellent. No one even told me about this until like, I had a PA that came from Texas that I worked with. We actually became really good friends. She was a pediatric PA. She'd done it for years. And that she was like, yeah, you can give them something. It's natural. It's called Zarbee's. It's at Walmart. It has a little bee on it. It's like a guava nectar or something, whatever. But it just coats their little lungs. So if mom's super stressed out, she's like, I need something. I need something for this kid. You're telling me to go buy nasal saline, a blue, no. You can say, go get some Zarbee's. They have it at Walmart. It's very cheap. It will help calm the cough a little bit. But mainly it's just nasal saline. With the blue. Y'all know what I mean by the blue bulb? It's that blue, it just sucks out, or nose Frida. I'm saying that right. This is crazy. You stick this little tube into your baby's nose and then you put the thing in your mouth and you suck, and it sucks all the snot. I bought what my baby had croup this winter, and it actually works. Because the blue bulb, they don't like it, they get mad and they fight you, but this little thing, you kind of put it in their nose and then you stick, it's like taking gasoline out of a gas. You sit there and you suck it, and it, you know, not hey, you never done that before. You just suck the snot out. So,
For gas?
yes.
Oh, yeah.
And then if you ever get that mouthful of gasoline, you know you went way too far.
Yeah.
Increased fluids. And then, of course, fever reducer. So this is just your basic how to treat. Fever reducer, Zarbee's, nasal saline, bulb suction, humidifier, push fluids is tolerated. You can do really close follow-up with your kiddos too if you're concerned. Like, come back and see me in 3 days. I don't want to admit you to the hospital or send you to the ER. In some cases, this is where the controversy comes in. Yeah, they have it in there. Steroids, I know some people will give kiddos oral steroids that have RSV. You can do that, it's not gonna kill them or anything. I mean, it's not, it's okay, you can do steroids. The only time, outpatient is usually the way they're gonna go with RSV. Send mom home with these things right here. The time when you wanna put baby in the hospital and you're thinking baby is not gonna support itself at home, or you don't really, and this is gonna happen, trust mom and dad, like they're kind of sketchy and you don't think they're really gonna do what you've talked to them about, that is another reason why you can admit a patient. So 2 biggies that'll get a baby admitted with RSV, not being able to eat or drink. Because when a little one gets really snotty and congested, they can't suck on a bottle because they're obligate, they breathe through their, they can't breathe. They stick that bottle in there, they're not gonna suck the bottle. So if baby's not eating or drinking per mom, and mom says baby's not pooping or peeing, she's giving me wet less diapers than she was yesterday, and they have signs and symptoms of dehydration in that physical exam, you're gonna wanna admit that baby. Because that baby needs to be monitored and they need to have fluids, IV fluids. Dehydration will take a kid out quick, very, very, very quick. They cannot maintain like us. The second thing that they're gonna need to be admitted for is O2, oxygen supplementation. If their O2 saturation is really low because of the inflammation from the virus, they need to be on oxygen. You can actually send a kid home with O2. They do it in the ER sometimes, but 9 times out of 10, they need to be in a controlled environment with oxygen on so that can be monitored. So a supportive care is still the mainstay, even though you can do supplemental oxygen and fluid replacement. Here's some of the controversial things. Bronchodilators, but bronchodilator would be like if you gave the kiddo albuterol. You sent them home with some albuterol. When I was on my family medicine rotations, they really did not do that for their inpatient babies. They would not give them albuterol that had RSV. But I know people do it. And the reason for that is when you give albuterol to a baby, it causes their little heart rate. It basically is like speed. I don't know if you guys knew that or not, but when you use albuterol, it makes the kid like wired up. So that's why a lot of people are very cautious with giving that to little ones. And if they're already tachypnic and their heart's racing because they don't feel well, that's gonna speed it up even more. So I don't ever give a baby albuterol, but I know a lot of people who do it. The first, second, third, fourth, the fifth bullet point, they actually did do this. I've seen this when I was on family medicine. It's called, I wrote it down, hypertonic saline. So what they do is they take saline and they put it in a nebulized, you know what saline is, right? Just stuff that drips in a bag. Hypertonic means a lot of salt. They would put it into a nebulizer and it would like aerosolize steam into the baby's face, nose. And what they think it's supposed to do is that salt particles that's in the nebulized saline, water follows solid, right? Water follows salt. So when baby breathe it in, it's supposed to pull all that mucus out of their little nose. That's the theory. And then they cough it out, or it runs out of their nose. Does it work? I don't know, but they do use that. You could probably look up a million studies on how to treat RSV. So that's what that bullet means. Do not memorize that dosing or anything of that nature. 6 grams and 300, don't do that. So steroids, albuterol, nebulized hypertonic saline, those are some of the ways that people will treat RSV. If there's obviously a secondary bacterial infection, OM, sinusitis, pneumonia, you're gonna have to get some antibiotics on board at that point, right? And we don't have to memorize that or anything. You'll get to your farm in a little bit. I was gonna say something else. There is an RSV prophylaxis. You can actually give this to babies. It is given, like when you take a child, or anybody that has children, I'm sorry, for their, well child checks, you can actually give this. I had a patient that was premature, it's twins, they were premature. They actually did this because obviously they were born before 29 weeks. Their lungs were immature and they needed that extra protection, so they did do this. You do not have to memorize that for your test. That's just, you do need to know that. These are just things you're going to talk to mom about. Wash your hands. Obviously, don't let baby kiss and slobber on other kiddos. No sharing of utensils. Here's another one that I had one of the attendees tell me, teach me, and it's actually, I was like, oh yeah, duh. For like when kiddos get conjunctivitis, you know how contagious that is. When kiddos get flu, RSV, whatever, and it's contagious. A lot of parents, I've done it, bathe kids together in the bath because you just want to save time and you're tired and you want to bathe them. Don't let them bathe them together because you can spread everything like that, especially RSV. It gets in the water. So no bathing of kids together. Obviously, any kiddo that gets RSV, and if they're hospitalized with RSV, not just everyday run-of-the-mill RSV, but if they're hospitalized with RSV because of a pneumonia or something of respiratory distress, yeah, their lungs are going to take a hit on that. So they will have abnormal pulmonary function tests later in life. Doesn't mean they're going to be at a disadvantage in life because they had RSV, but it can cause complications. Prognosis, kiddos usually get over RSV very quickly. I tell parents that usually a week, at least a week of coughing, runny nose, not wanting to sleep, not eating as much, fevers back and forth. Differential diagnosis, asthma, bronchiolitis, bronchitis, croup, pneumonia, influenza. These are all upper respiratory type infections, or they all present the same way for the most part. Okay, pertussis. Pertussis. Any questions over RSV? Very common. You're going to see it a lot in the winter months when you're out. PA Interwitz is going to cover it again because he will be talking to you about bronchiolitis. Number one cause of bronchiolitis in kids is RSV. And then you will be getting RSV again in your pediatric section. Pertussis is known as whooping cough. That's how a lot of people know it. Your parents have probably talked about it. It is a respiratory tract infection. It is, I hate that word paroxysmal. It always jacks me up. I feel like sit there and think about it, paroxysmal. It's just hard to say. That's what it is, that's like what it's known about. The whooping cough means paroxysmal cough. And I'll tell you a little bit what that means. Oh, I am so sorry. Somebody had a question a while ago on RSV, and I totally just skimmed over that.
I was just gonna ask, I've heard about research at OU about an RSV vaccine, and I didn't know if there was any talk about that.
I do not know, I don't know, I can't comment, I'm sorry.
That's good. That was a question.
Anything else about RSV that, because I rambled on a lot there, I'm sorry. I just have so much cool stuff I want to tell you from my practice that I like go into FISDI, and then I go into note-taking, and I tend to like throw out little pearls to you that'll help you later in your practice. Because again, we teach you to do well on boards, of course, but my thing is I want to teach you to be a good PA and treat patients. And you don't get that from a book. You get that from somebody saying, hey, this is how you do this. The organism is Bordetella pertussis. Oh, I remember. It's in red and golden. Vaccine was introduced in the 40s. So we have seen a decline in pertussis, obviously. Is anybody in here by show of hands know somebody that's had pertussis? Really?
My best friend in elementary school had
Was she not, did they not do
it. I don't know.
vaccinations? Was that not their thing? Okay. It would be, and that's why also going back to your history taking, when you have pediatric patients, besides do they go to daycare, do people smoke around them, I always ask about their immunization status, always. Is this kid immunized? Because if they're not, your differential just went from this to this. Because a lot of bad respiratory, GI, mojo can affect a kid if they are not immunized. But we do immunize against it, so we don't, I've never seen pertussis. It is a concern because pertussis can be very, very dangerous. So again, parents not believing in it or not being from the United States, those would be your two big scary, like, okay, maybe their immunizations are up to date. Pathophysiology, it is gram-negative bacillus. Humans are the only one that carry this. It is spread, obviously, you cough, and it's a pretty intense cough. It aerosolizes into the air. You pick it up that way, it infects the respiratory tract. And it's very damaging in that when it attaches to your epithelial ciliary, which those are those little finger-like projections that line your lungs, that kick stuff out. That's why we cough and get gunk up. It causes those to necrose and die off. So that's why you can't get stuff up with this. Your coughing is hindered. Your coughing's not hindered, but your ability to get stuff is. Sorry. Same thing. Transmission occurs direct face-to-face. Basically, if you get anything of secretions that are oral or nasal, whether it's touching, kissing, drinking, you're going to get it. It is extremely contagious. Extremely. Almost flu-like contagious. Influenza is extremely contagious. So is pertussis. They do believe, obviously, when a parent comes in and says, my kid's this, and the other, and you ask any sick contacts, 9 times out of 10, other family members are going to be infected with this. So mom will say, yes, me and my husband and little Joey over here have the same thing. Late summer, fall. It does, after a while, even as the protection from it does wear off when you get like a DTaP. That's what a DTaP is. Now, and I only know this because I've had 2 kids, with every pregnancy that you have, the OB-GYN gives you a follow-up pertussis, a follow-up DTaP. No matter, like I had my kids back to back, I got one with my first child and I got one with my second child. Every pregnancy you get it, just to protect against it, because it does wane and wear off. Obviously, kind of like with RSV, any individual that's premature or is immunocompromised in any way are gonna be more likely to have detrimental be affected by death, illness, more severe illness. And again, the third bullet point, not to just beat a dead horse here, they're gonna have to be hospitalized because of the things we already spoke about. Secondary bacterial infection, sepsis, respiratory distress. Those are things that are gonna get kiddo hospitalized. Pneumonia is big with this one. It can lead to a secondary bacterial infection. Incubation, 2 weeks, 1 to 2 weeks. So basically they can go be around someone and not have any stinking signs or symptoms for a week to 2 weeks, and then all of a sudden. And you may get that from time to time in your practice, where mom will come in and say, my kiddo's just fine, but there was an outbreak of this at their daycare. What do I need to do? Hopefully it wouldn't be pertussis. But they can show no signs or symptoms for a week to 2 weeks. Pertussis on average is a 6 to 10 week disease. That's a long time, isn't it? That's not your little common cold.
Yeah, she was like 2 months.
Yeah, they're sick. Not like mono sick, but it's pretty intense. So 6 to 10 weeks. It's divided into 3. Now, this is where you need to start going, ooh, she could test over this. Because this is differentiating, right? The other baloney, that doesn't really differentiate between RSV, does it? Other than the bug. But this is where you're going to be like, this is what tells me pertussis is pertussis and not influenza and not RSV and not asthma. So this is divided into 3 stages. The Cataral, love that, paroxysmal, and convalescent. I'm usually like with that. I'm pretty good. I know what I'm saying. So Cataral. It is, you can't really tell much about it from the URI. I mean, you're going to start out with just congestion, runny nose, cough, wheezing, low-grade fever, same old stuff that you see in anybody that has a common cold. They are most infectious at this phase, so they're doing a lot of viral shedding at this time period. They can have some tearing or conjunctival, I love that freaking word, whatever. Basically, they have watery eyes. Have you ever had a cold where you have red, bloodshot eyes and they're itchy and watering? So that's not that great, is it? They look like they have a cold. This is where it gets fun. So that's stage 1, Cataral. Very contagious, looks like a URI. Stage 2. This is where you're like, oh my gosh, when you hear a mom tell you this, you go, wow, I'm thinking pertussis. Or if you see this, you hear it yourself. Basically what they do, and you can obviously read this, I try not to just read straight off slides. They have this unbelievable like cough. I mean, like they're coughing. Have you ever seen somebody have a coughing fit almost, or you've had one yourself probably, where you just sit there and you cough for like 1 to 2 minutes. They'll stop coughing and they go, ooh, and that's the whooping cough. It's like, it's like they're catching their breath or something. It's odd. And again, we'll do it on YouTube and you'll be like, oh yeah. That's what the loud whoop is. Cough, 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 cough. And I mean, they're coughing, their face is blood red, their eyes are red, they are seriously coughing, and then they take that long inspiratory whoop. The third bullet point, don't pay too much. Younger ones don't so much have the, like you will hear it, because they just can't, kids don't know how to do that, they can't do that. They may just not breathe, they may have an apneic where they just sit there, not breathing, and then they go back into coughing. Post-tussive emesis, that is when a person like coughs so much that it makes them vomit, because they get gagged. You've probably done it before if you've ever had a really bad cold. They cough, cough, and vomit. That's what post-tussive, and it should say emesis to get real technical. Post-tussive vomiting. Stage 3